So the second MCQ discussion for today, the pretest was not that very good. The highest was 13 and the lowest being 11/20 on hemostasis in surgery. So now we'll commence the discussion. The first question says, which of the following is true of reactionary hemorrhage? Which of the following is true of reactionary hemorrhage? There are various ways you can classify hemorrhage. One is based on timing, which this question is all about. A, occurs during surgery. B, occurs 5 to 7 days after surgery. C, may be due to hypotensive anesthesia. D, can never be due to slippage of ligature. E, is usually due to post-operative wound infection. Now, you should know that hemorrhage are classified, one, based on timing. Based on timing, it could be classified as primary hemorrhage, reactionary hemorrhage, and secondary hemorrhage. When you say primary hemorrhage, is the hemorrhage that occur at the time of the procedure. When there is excessive bleeding at the time of surgery, that is primary hemorrhage. Now, reactionary hemorrhage is hemorrhage that occur in less than 24 hours of surgery. Now, patients with reactionary hemorrhage are usually hypertensive patients. You know, during anesthesia, the anesthetic agent will reduce the blood pressure. Now, after surgery and patient recovers from anesthesia, the blood pressure rises. Then the blood vessels open and patients bleed. Because when the blood pressure is low, blood clots could seal up some broken vessels. Or when there is ligature that is not properly secured, when the blood pressure resumes, there will be slippage of that ligature and patient bleeds. So it usually occurs within 24 hours. That is called reactionary hemorrhage, and it's common in hypertensive patients, and of course, that has undergone hypotensive anesthesia. So after surgery, with rise of blood pressure, there may be slippage of ligature or dislodgement of clot. Then they bleed. That is reactionary hemorrhage. Secondary hemorrhage occurs after 24 hours. And usually, this infection is due to infection. Now, if you look at this option, A says it occurs during surgery, which is false because primary hemorrhage occurs during surgery. Occurs 7 to 14 days after surgery. This is secondary hemorrhage, usually due to infection. Reactionary hemorrhage occur in less than 24 hours. Maybe due to hypotensive anesthesia. Yes, we said hypotensive anesthesia will lower the blood pressure. Then when patient recovers, they now bleed. Can never be due to slippage of ligature. This is false. We said it could be due to slippage of ligature or dislodgement of clot. It's usually due to post-operative wound infection. This is for secondary hemorrhage. So we said the answer is C. Surgical hemorrhage can be classified into primary, reactionary, and secondary hemorrhage. Primary hemorrhage occurs at surgery due to the incision and dissection during the surgery. It is best managed at the point of occurrence by adopting various hemostatic methods like clamping with artery forceps, and suture ligation, diatemy, harmonics, ligature, etc. Reactionary hemorrhage occurs within the first 24 hours post-surgery. It may occur due to slippage of ligature and returns to normotensive states following hypotensive anesthesia. Secondary hemorrhage commonly follows surgical site infection. These infections become apparent between 3 to 5 days post-operation, but the hemorrhage, which is due to erosion of blood vessels, tend to occur 7 to 14 days after surgery. Now, this point is very important. Usually, post-operative infection usually occur within 3 to 5 days. However, for the infection to lead to hemorrhage, that bleeding occurs 7 to 14 days. Number 2, which of the following addresses the risk factor for lower limb thrombosis? A, Saint's triad. B, Cushing's triad. C, Charcot's triad. D, Virchow's triad. E, Reynolds pentad or penterology. Now, it is very important you know all the triads in surgery, because you can see it may feature in an MCQ. Now, I believe you all know the component of all these triads that signifies different pathology. Saint's triad, of course, that is common in a jaundice patient, diverticulitis and hiatus hernia. Cushing's triad. Now, the triad in question here is lower limb thrombosis, which of course D is the right option. So we'll read the discussion. Now, venous thrombosis occurs when blood clot forms within the lumen of a vein and obstructs the blood flow. The risk factors have been classified by Virchow under 3 broad categories. Now, what are the components of Virchow's triad? Stasis, hypercoagulability, and vascular endothelial damage. These are the components of Virchow's triad: venous stasis, hypercoagulability, and vascular endothelial damage. Saint's triad addresses pathology of the hepatobiliary tract, gallstones, hiatus hernia, and colonic diverticulosis, while Cushing's triad, also called Cushing's reflex, is bradycardia with hypertension and irregular respiratory pattern in a patient that is coning from a raised intracranial pressure. It is associated with raised intracranial pressure and heralds coning of the midbrain herniation, especially following head injury with space-occupying lesion. While Charcot's triads comprises jaundice, fever, often with chills and rigors, and hypochondrial pain. That is right hypochondrial pain. It signifies cholangitis in a patient with obstructive jaundice that now present with right hypochondrial pain and fever. These are components of Charcot's triad. Patient is having cholangitis. Okay. Now, ascending cholangitis is when the cholangitis now involves the liver, where you have this triad. Also suggestive of ascending cholangitis in Reynolds pentad. Now, this Reynolds pentad is now a severe form of ascending cholangitis, where the patient has the patient will develop a low blood pressure, will tilt into shock, and they have altered sensorium. So it's a severe form of Charcot's triad. It has 5 components. All the 3 components of Charcot's triad, including hypotension and altered sensorium, makes up the Raynaud's pentad. Okay, lower limb DVT may be directly evaluated by the following radiological investigations, except A, pelvic ultrasound, B, Doppler ultrasound of the lower limb veins, C, chest X-ray, D, lower limb venography, E, X-ray of the lower limb. Now, this is an obvious option. C is not very relevant in evaluating lower limb DVT. Okay, so the answer is C. Complex duplex ultrasonography is the best radiological modality of evaluating DVT. However, color Doppler, option B, that gave color Doppler, and pelvic ultrasound have been found useful and preferred as they are non-invasive. They are non-invasive. Okay? Major findings will be non-compressible venous segment, which may be dilated in the early phase. The feature that will suggest DVT now is non-compressible venous segment, which may be dilated in the early phase with some probe tenderness. Dilated peripheral veins, loss of phasic motion on Valsalva maneuver. Now, an absence of color flow on Doppler interrogation. If the obstruction is total, there will be absence of flow. Other modalities available are venography, which is option E. Option E, a contrast X-ray. Venography is option D. E is a contrast X-ray. Magnetic resonance imaging and CT scan. So now, if you look at this question, chest X-ray is not a significant modality for evaluating lower limb deep venous thrombosis. Regarding anticoagulation therapy for deep vein thrombosis, in post-operative patients, of all of the following are true except, okay, A, pneumatic prophylaxis. B, heparin is an effective prophylaxis. C, aspirin is superior agent than Clexane. D, operation and immobility are risk factors. E, patients with antithrombin 3 deficiency are prone to thrombosis. Now, we are looking for the false option. We are looking for the false option regarding prophylactic or anticoagulation therapy for DVT in a post-operative patient. You know, there are some certain operations, major operations of the pelvis, operation involving malignancy. Okay, all these are risk factors for patients to develop DVT. Now, there are some modalities you take in preventing DVT, which could be mechanical or chemical. Now, the mechanical method will include intermittent pneumatic pump, pressure of the calf, use of TET stockings, embolic deterrent stockings. Okay, the chemical method, the use of drugs like Clexane, heparin, aspirin, and so on. Now, A is correct. They said which is false. A is correct. Heparin is an effective prophylaxis. Of course, aspirin is superior agent than Clexane. This is false. Clexane is a low molecular weight heparin, which is more effective than aspirin. So, operation and immobility is a risk factor. Yes, any patient that is operated and will last for more than 3 days, that is a risk factor. Prolonged bedridden is allowing a patient for more than 3 days. That is prolonged bedridden, and that is a risk factor. So operation and immobility is a risk factor for development of DVT. Patients with antithrombin 3 deficiency are prone to develop thrombosis. Yeah, so let us go through the discussion. Option, the answer here is C, is false, where aspirin is superior agent to Clexane. That is false. Deep vein thrombosis is a preventable event in surgical practice. DVT rates tends to be higher with prolonged pelvic and oncological surgeries and in patients on prolonged immobilization. Prophylactic measures can be instituted to mitigate its occurrence. These measures include early postoperative mobilization of patients, physiotherapy, use of elastic or compression stockings, and low molecular weight heparin. Okay, low molecular weight heparin like enoxaparin, Clexane, and Cutenox. Okay, in the immediate perioperative period, low molecular weight heparin are superior to other modalities. Thus, option C is not correct. You see, in the preoperative period where patient is mobile and all that, you can place patient on aspirin. Now, the next question, question 15, we've talked about virtuous triad, okay? Virtuous triad consists of the following except A, venous stasis, compression stockings are effective. That is correct. Neoplastic lesion is not part of the triad we mentioned earlier. Endothelial damage, correct. Hypercoagulability, correct. None of the above. We said the triad consists of venous stasis, hypercoagulability, and endothelial damage. So the answer here is B. Number 16. Okay, number 16. On splenomegaly, choose the best answer. On splenomegaly, choose the best answer. Now, tuberculosis can be a cause of splenomegaly. B, Feltis syndrome can be a cause of splenomegaly. C, cirrhosis can be a cause of splenomegaly. D, sickle cell disease, myeloproliferative disease, and lymphoma are the only causes of splenomegaly. E says all of the above. Now, this option requires you to choose the single best option. Now, if you look at these options, you realize that most of them are correct. So if you take E as all of the above condition can cause splenomegaly, that will be a single and most appropriate. So let us look at the discussion. Splenomegaly is a pathological enlargement of the spleen. It may result from trauma, mainly blunt abdominal trauma. And okay, we'll continue. Splenomegaly is a pathological enlargement of the spleen. It may result from trauma, mainly blunt abdominal injury. When there is hematoma, splenic trauma with hematoma, okay, most of the time subcapsular hematoma. Infection could be viral, bacterial, fungal, or parasitic, like malaria. Tuberculosis and pyogenic abscess are also common causes. Neoplasia, especially hematological myeloproliferative disease like leukemia and lymphoma, are also known causes. Connective tissue and inflammatory disease like lupus erythematosus, rheumatoid arthritis are known causes of splenomegaly. Feltis syndrome is a triad of neutropenia, rheumatoid arthritis, and splenomegaly. Other causes include liver cirrhosis because of portal hypertension, metabolic diseases, e.g., Gaucher's disease, hereditary spherocytosis, heart failure, sickle cell disease, and thalassemia. Number 17, select the best answer. That is, you should choose the single best option. Okay. Hereditary spherocytosis. Hereditary spherocytosis is okay. Select the best answer. Hereditary spherocytosis is never a cause of hemolytic anemia associated with splenomegaly. Sickle cell anemia is rarely associated with splenomegaly. Collagen disease is never associated with hemolytic splenomegaly. Drug reaction from sulfonamides is never associated with hemolytic splenomegaly. All of the above conditions can cause hemolytic splenomegaly. Because of the network challenge, we'll be a little bit faster now. Our answer is E. All of the above conditions can cause hemolytic splenomegaly. In addition, drugs like sulfonamides, chlorpromazine, mesalazine, and fluvastatin have been associated with splenomegaly and hemolytic anemias. On hereditary spherocytosis, choose the correct statement. On hereditary spherocytosis, choose the correct statement. A, the red blood cells are biconvex. B, the red blood cells are biconcave. C, the basic pathology is the absence of spectrin. D, can be diagnosed with saline load tests. D, diagnosis is not usually associated with saline, that is osmotic fragility tests. So our correct answer here is C. The basic pathology in hereditary spherocytosis is the absence of spectrin. We'll go through the discussion. Normal red blood cells have biconcave shape. In hereditary spherocytosis, the red blood cells are spherical due to abnormality of red blood cell membrane proteins. It is a familial hemolytic disorder with both an autosomal dominant in 75% and autosomal recessive 25% inheritance pattern. The disorder is due to mutation of genes that code for cell membrane proteins, especially spectrin, and to a lesser extent, ankyrin, band3, and protein 4.2, amongst others. This protein stabilizes the cytoskeleton that confer on RBCs their characteristic shape and ability to transfer blood vessels. The abnormally shaped RBCs have an average lifespan of 10 to 30 days, unlike normal red cells with 120 days. Clinical features are those of anemia, jaundice, and splenomegaly. Patients are more predisposed to gallstone disease. The condition is associated with Howell-Joel bodies within the red blood cells on blood smear. An osmotic fragility test is positive. Okay, the osmotic fragility test is used in evaluating patients with hereditary spherocytosis and thalassemias. These tests are not confirmatory. They are not confirmatory, but genetic studies are. The treatment is mainly supportive with blood transfusion, okay? Now, treatment for jaundice, you give hematinics and importantly, splenectomy. Now, you see, in a patient with hereditary spherocytosis, splenomegaly is the surgical treatment because as the red blood cell passes through the spleen, they are destroyed because of the abnormal structural protein in their cytoplasm. So you just remove the spleen to prevent the lysis of this cell. Concerning blood coagulation pathway, which of the following clotting factor does not belong to the intrinsic pathway? Intrinsic pathway. So you see from this question, you should read about all the coagulation cascades, the intrinsic pathway and the extrinsic pathway, and all those tests that assess intrinsic pathway, the blood tests that assess extrinsic pathway, and those that assess common pathway, because this can be an option. Okay, it can be a question. The following tests assess the intrinsic pathway. The following tests assess the extrinsic pathway. Okay. So A says plasma thromboplastin antecedent. B, Hedgeman factor. There's a typographical error here. Christmas factor, anti-hemophilic factor B. Proconvertin, that is stable factor. And E, anti-hemolytic factor A globally. So our correct answer here is D. D is the correct answer. The clotting cascade mechanism involves an interplay of three pathways. The intrinsic pathway activated by trauma, okay, to blood vessels, activated platelets, exposed endothelium, collagen, and chemical. 5, involve factor 1 to 10, okay, 2. Extrinsic pathway, also called the tissue factor pathway, okay, activated by exposure of injured tissue to blood and tissue factor. Okay, the common pathway involving 1, 2, 5, 8, and 10. The intrinsic pathway is longer and slower, while the extrinsic pathway is shorter and faster. The prothrombin time, PT, usually 10 to 12 seconds, assesses the extrinsic pathway, while partial thromboplastin time, PTT, okay, normal is 25 to 50 seconds, assesses the intrinsic pathway. So this information is very vital for your multiple choice questions. Which of the following factors belong to both the intrinsic and the extrinsic pathway? Which of the following factor belongs to both intrinsic and extrinsic pathway? Okay. A, tissue thromboplastin, that is factor 3. B, factor 7. C, factor 9. D, Stewart-Power factor 10. And factor 11. If you look at your coagulation cascade, you will find out that, okay, you find out that the factor 10 is the one that is common. It's belong to both the intrinsic and the extrinsic pathway. So our answer here is D. Choose the wrong answer concerning prevention of excessive coagulation. Choose the wrong answer concerning prevention of excessive coagulation. Now, we are looking for an except, the wrong answer. Thrombin is not initiated by antithrombin 3. Thrombin is not initiated by factor 9, 10, and 11. Thrombin is not initiated by fibrin degradation products. D, protein S and protein C, okay, from endothelial cells inhibit factor 5 and 8. Process cycling is of injured endothelium inhibit platelet aggregation. Now, you need to actually go back and review your clotting pathway, the pathways in detail. Get a textbook, read them in detail so that you get used to both the intrinsic and extrinsic and the common pathway. However, the answer that is false here is A. Thrombin is not inhibited by thrombin 3. Concerning modulation of coagulation, the following statements are true. Concerning modulation of coagulation, the following statements are true, except we are also looking for an except answer here. Plasminogen activator is derived from endothelium. Plasmin hydrolysis formed fibrin to fibrin degradation product. Fibrin degradation product can inhibit thrombin. Fibrin clot can also be removed by phagocytic cells. Okay. Fibrinolytic pathway is not an essential necessity. Fibrinolytic pathway is an essential necessity. So the one that is false is E. All these others are true. There is a natural mechanism involved in the prevention of excessive coagulation formation or formation of thrombosis. This mechanism constitutes the fibrinolytic. Okay, fibrinolysis is what forms the balance. It prevents excessive clot formation. Okay, now, so plasminogen present in the plasma is activated by tissue plasminogen activating factor on the endothelial wall to form plasmin, which degrades fibrin to fibrin degradation product. Fibrin activator inhibits plasmin activator inhibitors blocks the conversion of plasminogen to plasmin and further blocks some part of the clotting cascade. Fibrin degradation product can bind to thrombin to further inhibit its function. Okay, phagocytic cell play vital role in the recanalization of blood vessels. The following are procoagulant. The following are procoagulants, except what is not a procoagulant. A, thrombospondin. B, okay, B says 3-thromboglobulin, von Willebrand factor, fibrinogen, and calmodulin. Our answer here is E. Procoagulants are substances which promote both clotting pathways. Okay, thrombospondin is a matricellular glycoprotein incorporated in the cells like platelets, where it influences blood coagulation by promoting platelet aggregation and interaction with clotting factors. It also plays a role in angiogenesis, tumor metastasis, and cell proliferation. Similarly, 3-thromboglobulin forms part of platelet granules that are released during degradation of platelets. Von Willebrand factor is a glycoprotein that enhances activity and movement of clotting factors across vessel wall, while fibrinogen is a clotting factor. Calmodulin is a transmembrane protein that is involved in muscle function, where it interacts with free calcium, so it's not a procoagulant. Effect of long storage of blood include the following, except when you store blood in the blood bank, they lost viability of their contents, both the cellular content as well as the protein content. So, effect of long storage of blood include the following. Sorry, our network is quite poor. Okay. Effect of long storage of blood includes the following, except A. Factor 5 declines rapidly after 24 hours. That is correct. Sodium concentration in plasma reduces. This is false because sodium increases. Reduce ionized calcium in blood. This is correct because of the, what do you call it, anticoagulant that bind to calcium. Increase plasma potassium level because when the cell lyses, most of the potassium are intracellular. reduced level of 2,3 DPG. So B is the correct answer, which is false. The except answer, following prolonged blood storage, most clotting factors decline in activity except fibrinogen and thrombin, which are stable up to 21 days. So factor 2 and 1, they are the longest clotting factor that will remain in a stored blood. So the level of electrolytes, sodium and potassium increase, while level of calcium and activity of 2,3-DPG decline. Which of the following veins are valveless? Which of the following veins are valveless? A, vein of Bastin. B, superior rectal vein. C, inferior mesenteric vein. D, superior mesenteric vein. E, hemiazygous vein. Now, this vein of Bastin, of course, is valveless vein. That's why metastasis can flow through this vein to involve. Sorry for our disrupted network today. So let's just quickly round up. Most veins have valves which ensure unidirectional blood flow. Exception to these are brachiocephalic vein, okay, diploic vein, dural vein, venous sinus, portal veins, okay, the Pacian vein, vertebral venous plexus, that is the vein of Bastin, the emissary vein. Now, this vein of Bastin in the vertebra, they enhance free or flow of malignancy to involve the spine. Choose the wrong answer. Primary hemorrhage occurs, okay, primary hemorrhage occurs after surgery, 12 hours after surgery. Primary hemorrhage occurs during surgical procedure. Reactionary hemorrhage occurs within 24 hours post-operative. Secondary hemorrhage tends to be associated with surgical site infection. Uncorrected hypertension may be a cause of reactionary hemorrhage. We discussed this earlier, so our answer is A. Causes of reactionary bleeding may be due to the following, except A, oozing of blood from extensive raw area. B, necrosis of blood vessel. Okay. C, fibrinolysis and degradation syndrome. D, slippage of ligature from blood vessels. And E, dislodgement of blood clots. Now we are looking for the except option, except option. A is correct. B, is B correct? Not necrosis per se, because, well, let's see the other options. We'll get the best of fibrinolysis and degradation syndrome. This one is false. So the most appropriate here will be C. Slippage of ligature, that is correct. Dislodgement of blood clot is correct. So our answer here is C. 28, concerning surgical hemorrhage, all are correct except, all are correct except primary hemorrhage occurs during surgery. This is correct. Reactionary hemorrhage occurs within 24 hours. This is correct. Tertiary hemorrhage is the same as secondary hemorrhage. Okay, this is not